You're listening to Who Said, a Cardiology Board Review series. No fluff, just facts.
This episode is about Brugada Syndrome, including principles of diagnosis and management across the different types. Brugada syndrome is a syndrome of syncope and or sudden death in healthy patients with structurally normal hearts who have a mutation in the cardiac sodium channel gene most of the time. The incidence is high in Southeast Asia, where it was previously described as sudden unexplained nocturnal death syndrome, or SUNDS. Mutations in SCN5A are present in 30% of Brugada syndrome patients. Remember from the other episode that long QT3 is a gain of function mutation in SCN5A, whereas Brugada syndrome is a loss of function mutation in SCN5A. First and second degree relatives of a patient with Brugada syndrome who has a positive genetic test should undergo genetic screening regardless of the age of the relatives. A negative genetic test would effectively exclude the diagnosis of Brugada syndrome in these relatives. Brugada syndrome accounts for 40 to 60% of cases of idiopathic VFib. There are three types of Brugada pattern, all of which have pseudo right bundle branch block pattern in V1 to V3. Type 1 Brugada pattern is a coved morphology ST segment elevation of more than 2 millimeters in at least one of V1 and V3, followed by a negative T wave. Type 2 Brugada pattern is a saddleback morphology ST segment elevation of more than 2 millimeters in at least one of V1 to V3. Type 3 Brugada pattern can be of the coved or saddleback morphology of either type 1 or type 2 respectively, but the ST segment elevation is less than 2 millimeters. The appearance of type 1 Brugada pattern is enough to make the diagnosis of Brugada syndrome if there is one of the following clinical criteria present. 1. Documented VFib or polymorphic VT. 2. Family history of sudden cardiac death at less than 45 years of age. 3. Cove type ECGs in family members. 4. Inducibility of VT with programmed electrical stimulation. 5. Personal history of syncope. Or 6. Nocturnal agonal respiration. The appearance of any of these 6 clinical criteria is enough to make the diagnosis of Brugada syndrome in somebody with a type 1 pattern. In contrast, the appearance of a type 2 or type 3 pattern is not enough to diagnose Brugada syndrome clinically, and you would need either programmed electrical stimulation during an EP study or a drug challenge with procainamide or flecainide to make the diagnosis. Procainamide or flecainide is not done in type 1 Brugada because of the unnecessary risk of inducing polymorphic VT or VFib when you already know the diagnosis. If you see type 2 Brugada pattern, you need to repeat the 12-lead ECG with superior placement of leads V1 and V2. What is a high-lead ECG? In a high-lead ECG, the precordial leads are placed in pairs at the second, third, and fourth intercostal spaces on each side of the sternum. The high leads are labeled from top to bottom, left to right. Thus, HV1 and HV2 sit above HV3 and HV4, which in turn sit above HV5 and HV6. Note that HV5 and HV6 correspond to the V1 and V2 of the standard 12-lead ECG. This increases the sensitivity of the diagnosis as it allows for capturing variations in individuals' anatomic position of the RV outflow tract. The challenge is to distinguish between situations with underlying Brugada syndrome, such as typical resting Brugada pattern in true Brugada syndrome, and Brugada pattern induced by drugs such as sodium channel blockers that unmask Brugada syndrome, and also situations without Brugada syndrome underlying. This includes Brugada pattern that's induced by circumstances that disappear upon resolution of the injury and that do not represent Brugada syndrome phenocopies, such as acute ischemia, especially that of the RV, pulmonary embolism, drugs, pericarditis, myocarditis, metabolic disorders, ionic disorders, post defibrillation, electrocution, and hypothermia. These are all examples of circumstances that can cause temporary Brugada pattern and that do not represent Brugada syndrome. Then you also have Brugada like patterns that are permanent and easily confused with Brugada pattern, such as a normal incomplete right bundle branch block, athlete pattern, pectus excavatum, and arrhythmogenic right ventricular dysplasia, or ARVD. Sodium channel 1C blockers such as flecainide or profafenone can exacerbate the transient ECG abnormalities that occur in patients with Brugada syndrome who have commonly normal ECGs. The combination of type 1 Brugada pattern plus a PR prolongation over 200 milliseconds has a 40% positive predictive value for Brugada syndrome type 1, whereas a type 1 Brugada pattern with a normal PR interval has a less than 10% positive predictive value for Brugada syndrome type 1. While cardiac MRI is helpful in some cardiac conditions associated with arrhythmias, such as sarcoidosis or arrhythmogenic right ventricular cardiomyopathy, it does not play a role in the diagnosis or management of Brugada syndrome. What do the guidelines say about Brugada syndrome diagnosis? According to the 2017 AHA-ACC HRS guideline for management of patients with ventricular arrhythmias and her prevention of sudden cardiac death, in asymptomatic patients with only inducible type 1 Brugada electrocardiographic pattern, observation without therapy is recommended. Class 1. In patients with suspected Brugada syndrome in the absence of spontaneous type 1 Brugada electrocardiographic pattern, a pharmacologic challenge using a sodium channel blocker can be useful for diagnosis. Class 2A. In patients with asymptomatic Brugada syndrome and a spontaneous type 1 Brugada electrocardiographic pattern, an electrophysiological study with programmed ventricular stimulation using single and double extra stimuli may be considered for further risk stratification. Class 2B. Now that we've gone over diagnosis of Brugada syndrome and Brugada pattern, we'll switch over to talk about management. The most effective treatment for Brugada syndrome is an ICD. It is recommended as a class 1 indication in patients with type 1 Brugada syndrome who are survivors of cardiac arrest or who have had sustained VT with or without syncope. In these patients, the cumulative efficacy of an ICD is 18, 24, 32, 36, and 38% at 1, 2, 3, 4, and 5 years, respectively. So it is effective. ICD placement can be useful as a class 2A indication in patients with spontaneous, i.e., at rest, type 1 Brugada ECG pattern, and a history of syncope, seizure, or nocturnal angular respiration that is judged to be caused by ventricular arrhythmias, as long as a thorough assessment has been performed to exclude non-cardiac causes of these symptoms. In contrast, in asymptomatic patients, ICD placement may be considered class 2B indication if there's inducible VT or VFib on program stimulation. If there's no inducible VT VFib on program stimulation of the asymptomatic patient, ICD should not be placed. Before you decide to implant an ICD, you need to evaluate if the patient is having syncope that is vasovagal. ICD should not be implanted in Brugada syndrome patients who are having exclusively vasovagal syncope. They will just end up having a whole bunch of inappropriate shocks. Instead, patients with a syncope prodrome should be instructed to assume a supine position to prevent a fainting episode and minimize possible injury. In patients with a sufficiently long prodrome, physical countermaneuvers such as leg crossing, limb and or abdominal contraction, and squatting are a core management strategy. In asymptomatic patients who do not have an indication for ICD placement, it should be emphasized that the rate of cardiac events is actually quite low, at 0.5% per year, compared to the rate of long-term device-related complications that is 16%. Because Brugada syndrome patients can live quite long, especially if they have ICDs and are able to engage in normal everyday activity, they have a greater propensity to develop lead fractures, require multiple generator exchanges, and suffer from inappropriate shocks. In general, inappropriate shocks occur 2.5 more times frequently than appropriate shocks over the lifetime of ICD use. Drugs that inhibit the ITO channel or augment the ICAL channel are helpful in Brugada syndrome because they can restore the RV epicardial action potential dome, normalizing the ST segment and preventing phase 2 reentry and ventricular arrhythmias in Brugada syndrome. Quinidine is a 1A antiarrhythmic that blocks the ITO channel quite strongly and can suppress arrhythmia inducibility in 76% of Brugada syndrome patients. When should you give quinidine? Quinidine, the 1A antiarrhythmic, is used in 3 situations in Brugada syndrome. 1. Brugada patients with an ICD that is giving them multiple appropriate shocks. 2. Brugada patients who cannot get an ICD. And 3. Brugada patients who are experiencing supraventricular arrhythmias. These are the situations where you can use the 1A arrhythmic quinidine in Brugada syndrome. Disopyramide, another 1A antiarrhythmic, has less efficacy but is also acceptable in place of quinidine. Bepredil and tadalafil are ITO channel blockers that are currently being tested. Cilostazol and milrinone are PDE3 inhibitors that augment ICAL and reduce ITO and are being tested for suppressing ST elevation and arrhythmogenesis in Brugada syndrome patients, but do not have a recommendation yet in the current guidelines. Never use beta blockers in Brugada syndrome because beta blockers can increase ST segment elevation. Avoid amiodarone in Brugada because it can unmask ST segment elevation and can be proarrhythmic. When should you give isoproterenol? Isoproterenol, denopamine, and orciprenaline are beta agonists that have been useful in treating VTAC or VFib in patients with Brugada syndrome. Before using it, you have to be absolutely sure that the patient has Brugada syndrome because VFib arising from other mechanisms such as CPVT can have devastating consequences if given isoproterenol. Be sure to counsel patients to avoid Brugada aggravating drugs, avoid alcohol and cocaine, and treat fever because all these things can trigger Brugada related ventricular arrhythmias. In contrast, ARVC patients can freely take alcohol and caffeine and have fever because those do not trigger VT and ARVC. The drugs to avoid in Brugada include the following: antiarrhythmics such as flecainide, procainamide, and profafenone; psych drugs, nortriptyline, amitriptyline, lithium, and clomipramine; anesthetic drugs such as propofol and bupivacaine; and others such as alcohol, cocaine, ergonovine, and acetylcholine. A full list can be found online on our Brugada Drugs website. What antiarrhythmic should you avoid in Brugada syndrome? 1C, flecainide and profafenone, and some 1A, procainamide and adrenaline. These antiarrhythmics have predominant sodium channel blocking effects and will worsen ST elevation and propensity for VT-VFib and are contraindicated. Beta blockers also worsen ST elevation and should be avoided. In contrast, 1B agents such as lidocaine and mexiletine are antiarrhythmics that block the fast INA mainly at fast heart rates and have little to no effect on fast INA channel at moderate or slow heart rates. What factors modulate ST segment elevation and arrhythmia initiation in Brugada syndrome? Bradycardia and vagal tone can contribute to ST segment elevation and arrhythmia initiation. That is why arrhythmias and sudden cardiac death tend to occur in the middle of the night in patients with Brugada syndrome. Temperature also modulates the phenotype. Febrile states may unmask Brugada syndrome in certain patients and can temporarily increase the risk of arrhythmias. The role of hormones is being debated, but higher testosterone seems to be associated with more Brugada syndrome manifestations. When should you send to catheter ablation? In Brugada syndrome patients with a history of antiarrhythmic storms or repeated appropriate ICD shocks, catheter ablation may be considered with a Class 2B indication. The trigger for VT in Brugada syndrome patients is usually monomorphic PVCs originating from the RV outflow tract or RV Purkinje network. So radiofrequency ablation would target the epicardial arrhythmogenic substrate in the RV outflow tract and RV anterior wall. Let's wrap up by discussing what the guidelines say about Brugada syndrome management. According to the 2017 AHA-ACC-HRS guideline for management of patients with ventricular arrhythmias and the prevention of sudden cardiac death, in patients with Brugada syndrome with spontaneous type 1 Brugada electrocardiographic pattern and cardiac arrest, sustained ventricular arrhythmia, or a recent history of syncope presumed to be due to ventricular arrhythmia, an ICD is recommended if meaningful survival of greater than 1 year is expected. That's a class 1 recommendation. In patients with spontaneous type 1 Brugada electrocardiographic pattern and symptomatic ventricular arrhythmia who are either not candidates for or decline an ICD, quinidine or catheter ablation is recommended as a class 1 indication. In patients with Brugada syndrome experiencing current ICD shocks with polymorphic VT, intensification of therapy with quinidine or catheter ablation is recommended, class 1. That's all for diagnosis and management of Brugada syndrome.
This podcast is intended for qualified healthcare professionals and is designed for training purposes only. These materials should not be used for direct patient care or as a substitute for independent clinical judgment. For more educational content or to submit suggestions, visit www.rehu.com/meded.